This technique describes a medial ligament complex reconstruction with allograft using a less invasive onlay fixation and suture tape augmentation. These are our pertinent disclosures. On diagnostic arthroscopy, there is noted to be a positive drive-through sign on examination of the medial compartment. On further inspection, there is noted to be a high-riding medial meniscus with a hemorrhagic undersurface along the meniscotibial ligament signifying disruption here. Prior to reconstruction of the medial ligament complex, the MTL is first reduced and fixed back to the tibia through an open hockey stick incision. With the use of fluoroscopy, the isometric point is located on the femur where a drill pin is then placed. During initial dissection and during placement, drilling of the femoral tunnel on the isometric point, an anterior tibialis allograft is prepared. The graft is doubled over and an adjustable loop device is placed on the fold. The posterior oblique ligament limb is measured to be 95 millimeters in length, and the superficial MCL limb is measured to be 170 millimeters in length. The two limbs are sutured together just distal to the loops of the ALD. The suture tape comes incorporated in the ALD's button, which will act as an internal brace for the superficial MCL. An 8mm acorn reamer is drilled over the drill pin to a depth of 40 millimeters. A shuttle suture is placed within the eyelet of the drill pin and brought laterally. With the semimembranosus retracted inferiorly, a 2.6mm soft, knotless anchor is placed within the POL's footprint. The distal attachment side of the superficial MCL is marked 6 centimeters distal to the joint line. A second 2.6mm soft knotless anchor is placed at the distal attachment side of the superficial MCL, with a third anchor placed 2.5 centimeters proximal to the distal anchor. The ALD is shuttled through the femoral tunnel. Be sure not to include the suture tape in the shuttling. The graft is marked at 30 millimeters distal to the ALD and hoisted 30 millimeters into the femoral tunnel. The POL limb is brought through the two knotless loops anchored at its attachment site. With tension on the POL distally, with the knee in full extension, the most distal loop is tightened down. The POL limb is doubled back proximally, and the proximal knotless loop is then tightened down with the knee fully extended. The superficial MCL limb is brought through the 4 loops along the course of its attachment sides. The pes tendons retracted posteriorly and with the knee in 20 degrees of flexion with a varus stress, the 2 loops associated with the most distal anchor are tightened down. The femoral ALD is then tensioned. The superficial MCL is then doubled back through the more proximal loops, and with the knee still flexed at 20 degrees, the loops are then tightened down. The knee is then subsequently cycled. With the knee fully extended, all loops are retensioned. A 4.5mm hole is drilled between the 2 fixation points of the superficial MCL, which is then subsequently tapped. The suture tape is threaded through a 4.75mm bioabsorbable anchor and fixed in this hole with the knee fully extended. Following final fixation, the suture tape can be seen running between the superficial MCL limbs and the POL limb is visualized posteriorly. Viewing through the anterolateral portal, the drive-through sign is noted to be eliminated. Additionally, the medial meniscus is seen to be reduced back down to the tibia.